All right, Mr. Ladner, the floor is yours.
All right, we good. Choose the stroke protocol today. Seems to be something we get a pretty good bit of. Of course, if we get called for a stroke, altered mental status, we want to rule that out. I guess the most prominent factors of having strokes: AFib, previous strokes, high blood pressure, diabetes, um, heat exhaustion, things like that. We always warrant one. When we first find somebody with signs and symptoms of a stroke, whether it be slurred speech or aphasia or um, one-sided weakness, you always want to rule out diabetic incident, so you want to check blood sugar. And of course, recognize it and then make an alert for it. And of course, getting the line established, running a 12 lead, all that as far as the paramedics goes. BLS is mainly just assessing for it, finding it, and activating it so that Katie can know and pray to get them to the hospital, to the appropriate hospital. As far as IVs go, they're probably going to go straight to cath lab as soon as they get, not cath lab, CT, as soon as they get there. It's good to get an IV from the AC and up because it's a larger vein and it can handle the contrast. If you only have a smaller IV, so like a 22, they can do it. It's just that if you get one in the hand, it's probably going to cause them a lot of pain when they get contrast, because when they shoot the dye through and then do the CT with the radiology, it causes burn. Other than that, that's pretty much it as far as a stroke, is recognizing and activating it. There's really no drugs, of course, to give for this. I know we have metoprolol in our kit, but I don't know if you see that in the protocol as far as managing their blood pressure or anything like that. But also looking for any underlying issues too. Do I have any questions on that?
Hey, yeah, I may have missed what you were saying on the IV. Are you saying do not do an IV? I'm not quite sure I caught that correctly.
No, I was saying you would want to try to get a larger IV in the AC or above due to the contrast whenever they go to CT. It can
Sure.
cause a pain in their arm from the dye and when they go through the CT machine, it causes it to pretty much burn.
Right. Also, the other question I had was, are we still doing a gray alert, a stroke alert? Are we calling that in? Is that changed?
I haven't seen that. They didn't say that they have stroke alert in the protocols. Now, I've always called it because it's in our report that we have to, it's a stroke activation, so on and so forth. And it starts with us because they're going to call it when they get to the hospital, whether that ambulance crew calls it or not. That would be in their report as well whenever they transport. But I would do it just so that, hey, we've got they meet the timeline, which is 4 hours from time of recognition into the time of CT or radiology intervention. So I would definitely do it, and also notate the time of onset of symptom if there's a known time.
Thank you.
Are we contemplating calling the helicopter, or we have?
The longer than 15 minutes is what our protocols say, as far as that's just about anywhere north of West Worthing if they're going to Memorial.
Yeah. Yeah. So
probably a little further south than that.
If you have an extended response time and ambulance is going to be there after you and they have witnessed onset, we're still inside our 4-hour window.
Yeah, longer than a 15-minute ground transport time is what it's saying here. For a level 2, level 1 stroke center. Of course, they may try to go to Singing River to hurry up and at least get CT and do it.
Yeah.
TPA. But as far as a bleed or anything, I don't think they can do anything much there as far as they really need radiology intervention, which would be a Memorial.
Gotcha.
'Cause they have
Yeah, I
no-
think the thing the thing to not forget, um, we need to stress time is brain. And the longer they're compromised, the greater the deficit could be. So obviously this is a situation where you don't waste any time, correct?
Yeah, and it lowers the chance of recovery.
So if,
Spending time.
if we are gonna fly them out, cause say we get a stroke in Ken's area, are we waiting on Acadian to make that call, or can we make that call if we can get an ETA from Acadian?
As far as I know, we can make it.
Yeah, I would say we make it.
Okay,
Do something.
No, definitely
Yeah.
100%. We make the call and then we can determine from there where it goes. But yeah, whoever makes the call, because you're looking out for the patient first.
15 minutes when we get the last room. Transport time from the location of patient to the facility, greater than that. It's gonna be 30 minutes to get. Yeah, so yeah, you make that call, especially if you know, dispatch reports that the RPs witnessed, you know, witness onset. We have you know, our clock started, of course, we have all the other times, but absolutely, 10's run. They never flew them, but I've called before, the 10's run. Just because it took me 18 minutes to get there. And I'm ahead of the transport unit most of the time.
Yep.
You got any other questions about it?
Hey, let me say this for a moment. When you look back through our call logs and stuff, you see that we get dispatched out to several strokes a day, several possible strokes a day.
Mhm.
The general public calls anything altered with head pain a stroke. I can't tell you those numbers. I can't tell you what they turn out to be, but just make sure you do a very good assessment, like they were saying. Make sure you find out your onset of symptoms, and then determine your course of action and stuff like that. I guess what I'm saying is, as much as I want to make sure we get the patients to the right places, be hesitant on calling that helicopter every single time dispatch sends us to a stroke call.
For
Make
sure.
sense?
Yeah, for sure.
And the other thing I want to say is, we always are the ones that request the helicopter. All right. That question comes up often or whatever. Just so everybody's aware, we request the helicopter through our dispatch. We don't have Acadian do it. Acadian doesn't request a helicopter. They can, but we request a helicopter through our dispatch. We don't have Acadian requesting it. All right.
And just request they call the helicopter, not check, because they may get confused. I know we've had that issue before. You know, check on Rescue 5, like just call them for sure. Because they don't, sometimes dispatch gets confused. And then they have to call you back and be like, do you want them? Or are you just wanting to know if they can come? So good deal. You good, Cam? You got what?
Yeah, we're gonna knock out one more that we probably don't see very often.
All right.
We go to pediatric bradycardia. So, of course, any peds call is not fun. But I guess the main thing to look at for that, ABCs be the first thing to check for, because most pediatric arrests or calls or respiratory is going to be the underlying cause. Of course, check for any foreign bodies, because peds are going to be prone to put things in their mouth. Obviously you're gonna check the rare occasion of new onset diabetes, if they may have ingested something such as, got a hold of mom's or dad's drugs or what have you. And of course, if it's pediatric, less than 60, we're pretty much gonna go into CPR and follow that protocol. That introduces your establishing IV, you get your, epi 1/10,000 as well as, atropine. The drug dosage for that, for epi is gonna be 0.01 milligram per kilogram. I think with a max of 0.1. And then your atropine dose is gonna be 0.02 with a minimum of 0.1 with a max of 0.5 milligrams. So that's gonna be our, uncommon dosages. Of course, we have a Brazo tape, that'd be your go-to. It's all right there, it's on the tape. And it's you stretch it out from head to toe, all your dosages are there according to weight. But the main thing, of course, trying to find those underlying issues to fix the problem, not necessarily the result of the incident. Anybody have anything to add to that?
Do we have Brazo tapes in all the ALS kits?
I know I have one in mind.
You have one? I know 11 has one.
I got one myself too.
Let's, can we verify that today? Let's find that out. That'd be bad day to find out we didn't have one. So what do we got? 7? Cam, you said you got one? Dale, you got one at 11? Mr. Hardman, you said you got one. You said squad's got one, Ms. Lassard? Yeah, okay. So, if we hadn't seen it in a minute, let's double check that for sure.
Hey Cameron, what was the age for CPR if under 60 beats a minute? What was the cutoff?
I think it's gonna be less, I know for sure less than 1. But in the protocol, I don't even give an age. But I guess I would follow the AHA. What they say. Let's see. I just had it pulled up. Maybe less than 2 years. Like I said, if you see something that contradicts that, then let me know.
Cameron, I got a question on that. As you know, most medications are passed through breast milk from the mother to the child. Should we ask the mother if she's been on any pain medication or anything like that, just to double check?
Yeah, for sure. I'm not 100% on which ones do and don't pass that barrier. But
In most like doctors, unless it is actually like the OB, most doctors don't know what medicines are passed through breast milk. They'll tell you they don't know, ask the pharmacist.
I know some doctors they'll prescribe stuff that others may say it's not okay, and other doctors say it's okay. I've seen that several times too. Also depends on what doctor you ask. Cause they'll say it's just such a minute amount that they won't affect anything. Let me see what this is. Thanks. Oh, of course, another thing to consider would be external pacing. Last ditch effort. Obviously, you wouldn't want to start at 70 and 70 as a normal adult. Start at the bottom and work your way up till you get captured. And if you get captured, make sure you confirm it with a radio or peripheral pulse, pre-brachial for infants.
Good deal. Anybody else got anything to add to that? Nope. All right, well, thank y'all. Appreciate your time. Y'all have a good day. Drink water.